my name is Danny. I'm a nurse practitioner student. I'm going to be doing a complete head to toe assessment of you today. Do you have any questions? Okay. I'll be instructing you on each piece as we go along, and I'll tell you in any way that you can assist me. Okay. So I'm beginning by assessing her general state of health. She looks in good physical health, no appearance of emotional and physical distress. Throughout the exam, I'll be looking at skin, looking for temperature, turgor, any signs of lesions or rashes, and any scarring. First, I'm going to start with assessing your hands. Spread your hands out for me. I'm looking at the joints, looking for any deformity, warmth, swelling, or tenderness. Any pain here? Okay. Looking at the nails, looking at cap refill, which is brisk, less than 3 seconds. And go ahead and do this for me. Okay. She's got a positive diamond window, so no clubbing. And then I'm going to have you squeeze my fingers for me. Okay, she's got good grip strength, 5 out of 5. Moving up, looking at the wrist joints here. Any pain there? No redness, warmth, or tenderness. I'm going to feel for the pulses of your wrist here. So feeling the radial pulses. They're equal bilaterally, 2+ out of 4, not bounding or thready. Rate is approximately 75. Rhythm is regular. As I move up the arms, I'm assessing for symmetry, any muscle atrophy, any pain, tenderness, warmth, or swelling. Any pain there? Okay. Feeling the Okerman processes on both sides for warmth or swelling. Any pain? Okay. I'm going to have you move your elbows for me. So go like this for me. That's flexion of the elbow and then out, extension. And then you put your palms toward the ground. That's pronation and back up. That's supination. So full range of motion in the elbows. Now I'm going to feel your shoulders here. Any pain or tenderness there? Okay, feeling the glenohumeral joint of the shoulder for any warmth, tenderness, or swelling. Now I'm going to have you move your shoulders for me. So put your hands up over your head. That's flexion of the elbow, and then back behind your waist. That's extension of the elbow. Now I'm going to have you put your arms across your chest. That's abduction, and then up over like this. That's abduction. I'm going to have you next put your hands behind your neck. That's external rotation of the shoulder, and then back behind your back, and that's internal. And I'm leaning behind to make sure that you have equal symmetry of internal rotation of the shoulder. Great. So next, I'm going to assess the strength of your muscles. So I'm going to have you pull up against me. Good. That's bicep strength, and push down against me. That's tricep strength. Now hold your hands up like this. I'm going to push down, resist me, okay? And that's deltoid strength. They're all 5 out of 5 in all of those regions. So I'm moving on now to first assess your head and your neck and your eyes and ears. So looking first at the hair and behind the ears, looking for any rashes or infestation. I see no areas of patchiness or bulging. And now assessing the eyes. I see no sign of lid lag, exothalamus, or edema. Eyes are symmetrical bilaterally. Do you wear any corrective lenses? Okay. Okay, so that's the beginning of my assessment of cranial nerve 2 optic. I'm now going to be looking in your eyes at the sclera and just the health of the outside of your eye. So I'm going to be pulling down the eyes here, and just move your eyes back and forth. Good. So sclera is white and conjunctiva is clear. I'm going to have you just follow my finger with your eyes. Try not to move your head. So I'm looking at cranial nerve 3, ocular motor. Cranial nerve 4, trochlear, and cranial nerve 6, abducen. For extraocular movement, which is present, and any nystagmus, which I don't see. Next, I'm going to be looking at cranial nerve 2, optic, and cranial nerve 3, ocular motor for pupillary constriction and accommodation. So I'm just going to have you looking straight ahead for me. I have direct pupillary constriction and consensual pupillary constriction. Now the other eye. direct, and consensual. Now I'm going to have you look at my finger here and then pick a point in the distance and look off and go back and forth for me. So I have constriction up close and dilation out far, which is accommodation, which again is cranial nerve 2, optic, and cranial nerve 3, ocular motor. So now I'm going to be looking at the health of the back of your eye using the ophthalmoscope. So I'm going to be coming in close to you. I'm going to raise you up here on the bed a little bit. Using my ophthalmoscope, you put my hand on your head here, coming in at a 15-degree angle, finding the red reflex. And coming around to the other side. In both eyes, I note the red reflex is present, disc margins are sharp, disc color is peachy in color. In all four margins, I see no AV nicking, hemorrhaging, or lesions. So next, I will be moving on to the assessment of the acoustic cranial nerve 8. So I'm going to have you occlude one of your ears. We'll start with this one, and I'm going to whisper a series of numbers and letters. I want you to tell me what you hear. 7, 8. Okay, now we're going to do the same on the other side. 8, 2, 9. Wonderful. Okay. Now I'm just going to feel your ears. I want you to tell me if there's any pain or tenderness. So I'm feeling the auricle and the tragus. I don't note any discharge or swelling or warmth. Any pain there? Okay. Now I'm going to be looking at insides of your ears. So pulling up, back, and out. Come around to the other side. In both canals, I note no discharge, swelling, or redness. Tympanic membranes are both pearly white, mid-position. I see good cones of light, and bony landmarks are present. No bulging or perforation of the membranes. So next, I'll be moving on to cranial nerve 1, olfactory. So any changes in your sense of smell, any difficulty smelling coffee in a coffee shop? Okay. So next, I'm going to be looking inside your nose. Any pain or issue with your nose lately? Okay. So I'm going to raise you up here again a little bit. Go ahead and tilt your nose back for me. Okay. Bracing against the patient here. And inferior turbinates are pink. I don't notice any masses, lesions, or polyps. And septum is midline with no deviation or perforation. So now I am going to be assessing cranial nerve 7 facial and cranial nerve 9 glossopharyngeal. So I'm going to have you I'm going to have you open your mouth for me. Any trouble with taste lately? Okay. Looking inside the mouth, I see no sign of mucosa is pink. I see no sign of any lesions, masses, no leukoplakia. Dentation is intact, no sign of caries. Go ahead and lift your tongue up Good. And I see no swelling of the ducts, no signs of masses or lesions underneath the tongue. Okay, you can put your tongue back down, open up wide, and stick out your tongue. Say ah. Good. You can stop. The uvula rises is midline, and the soft palate rises and falls symmetrically, which is cranial nerve 10 vagus. I'm going to go ahead and just feel around in your mouth and palpate. Again, no masses or lesions under the tongue, around the tongue, and in the lips. Next, I'm moving on to cranial nerve 5, which is trigeminal. I'm going to feel the muscles of your jaw. So I'm going to have you go ahead and clench for me, okay? And then open and close. So I feel no crepitus or swelling at the jaw. I do feel a bit of clicking. Is that painful for you at all? Okay, good. Next, and I see no overbite. Next, I'm going to be assessing your cranial 7. You have facial nerve. So go ahead, open your eyes up wide for me, okay? And then smile big for me, frown, show me your teeth, pop out your cheeks for me. Good. I'm going to have you squeeze your eyes closed and try not to let me open them. Okay, great. So next, I am going to be assessing your cranial nerve 12, your hypoglossal nerve. So go ahead and stick your tongue out at me, okay? And move it side to side. Okay, and then put it back in your mouth and stick it against your cheek here. Okay, and cranial nerve 12 hypoglossal is intact. Tongue is midline, and I don't and strength of tongue is intact. So next, I'm going to go back and assess cranial nerve 11, which is spinal accessory. So I'm going to have you shrug your shoulders against my resistance. Good, and that's trapezius muscle strength is intact. And then push your hand against my cheek. Or put your cheek against my hand, excuse me, and that's sternocleidomastoid strength, which is also intact. Now I'm going to assess your lymph nodes, okay? So you're going to feel me touch. So it's preauricular, postauricular, occipital, tonsillar, submandibular, submental, superficial cervical, deep cervical, posterior cervical, supraclavicular, infraclavicular. And now we're going to do some range of motion of your neck. So I'm going to have you touch your chin to your chest. So that's flexion of the neck, and then back, that's extension of the neck. And then have you turn your neck towards the good, and then back the other way. That's rotation of the neck. And then I'm going to have you bend your ear towards your shoulder. Good, and the other way. Good. And that's full range of motion. I don't note any crepitus in the neck as the neck turns. So next we will, I'll be assessing your neck and your thyroid. So I'm going to give you your water here. I'm going to have you go ahead and just take a sip for me. Good. Okay. So I noticed that trachea is midline during swallow. I don't notice any visible goiters or visible masses. So I'm going to have you be taking some sips of water again. I just ask that you hold the water in your mouth and wait for me to tell you when to swallow. I'm going to come around behind you, and I'm going to be placing my hands on your neck from behind. So tip your head down for me there. Okay, go ahead and take a swallow. Okay, and I'm feeling the isthmus of the thyroid. Now take another sip for me. And then tilt your head to the left. Okay, and swallow. Good. And one more sip. And tilt your head to the right and swallow. Good. And I'm feeling for both lobes of the thyroid, and the thyroid does not feel enlarged. Okay. Good. I'm going to remain back here, and I'm going to have you take a nice big deep breath for me. Good. And I'm noting the AP diameter of the thorax is less than the lateral diameter, and noticing that the symmetry, there's symmetry in the expansion of her thorax when she breathes. I'm going to place my hands on the 10th rib and where my thumbs meet. Go ahead and take another nice deep breath for me. Good. And expansion is symmetrical and my thumbs part less than 3 centimeters. I'm now going to feel down your spine. You let me know if anything's painful or tender. So starting at around C7, I'm feeling each spine's process, looking for any step outs or protrusions. Down to the gluteal fold. I don't note any pain or tenderness there. Now feeling the paravertebral muscles, looking for any tremor or vesiculation, any spasming. I don't note any there. I'm now going to be listening to your lungs. So every time I place the stethoscope, feels like that, on your back, I want you to take a nice big deep breath with your mouth open. Okay. Good. In the posterior lung fields, I hear bronchovesicular sounds, no wheezes, crackles, or rails. I'm going to just lift your arm up and listen to the right side here. Good. Good rest. Again, in the right lobe, I hear bronchovesicular breath sounds. I hear no wheezes, crackles, or rails. We're going to do the same in the front. So again, nice big deep breaths open. And in the anterior lung field, I hear no bronchovesicular breath sounds, no wheezes, rails, or rhonchi. So now I'm going to listen to your heart. You can just take normal breath sounds from here. So starting at the second intercostal space on the right sternal border, I'm listening at the aortic valve. I hear S1, S2, no S3, S4, or murmurs. Moving over to the second intercostal space on the left sternal border, it's the pulmonic valve. I hear S1, S2, no S3, S4, or murmurs. Moving down to the left sternal border, the tricuspid valve. I hear S1, S2, no S3, S4, or murmurs. I'm going to have you lift your breast tissue on the left side here. Going to the fifth intercostal space on the midclavicular line. This is the mitral valve. Again, S1, S2, no S3, S4, or murmurs. I'm now going to feel your carotid pulse. So this is the pulses in your neck. So feeling one carotid pulse at a time. The other. They're equal bilaterally, about 2+ out of 4, not bounding or thready. Rate is approximately 75, and rhythm is regular. Now going to listen with my stethoscope. I ask that you just not cough or speak while I do this. I do not auscultate any buoys. So next I'm going to be feeling for the nodes that are located inside of your armpit. It may feel a little uncomfortable, okay? Just rest your arm in my hand. Feeling for the central nodes here. Side. And I don't note any enlarged nodes, hard or fixed nodes. Do you feel any pain or tenderness there? Okay. So next we're going to be doing the breast exam. First I'd like you to place your hands on your hips and squeeze your chest muscles for me. Okay, while I examine the breast, I'm looking for any asymmetry, any dimpling, any skin changes or venous pattern changes, and looking for any areas of immovability. Now I'm going to have you raise your hand up over your head. As she raises her hands, again, I'm looking for any changes in symmetry or any areas that do not move with her movement. Now you can put your hands down. I'm going to have you rest back while we do the physical examination of your breast. So I'm going to have you turn your hips away from me and place your hand up over your head. And when the time comes, I'm going to have you move your hips back towards midline, okay? So as I move through the breast exam, I'm going to start in the axillary tail and move down to the rib cage in a vertical stripe with the palms of my fingers moving in a circular motion, moving 3 different types of touch, light, medium, and deep. So starting in the tail here, light, medium, deep, 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 all the way down the tissue. Be looking for tissue consistency, any masses, immovable lumps, light, medium, deep. Try not to lift my fingers. When I reach the nipple line, you can now move your hips back and in line and then bring your hand down to your ear. Looking at the nipple for any discharge. Moving towards the breast tissue at the sternal border. Now I'll repeat the same on the other side. So I'm going to have you put this arm down, place that arm back up over your head, and then tilt your head towards me. Again, starting in the axillary tail and moving down with the same motion. Anything painful or tender for you so far? Good. And now at your nipple length, I'm going to have you move your hips back again towards the middle and then place your hands back down towards your ear. Again, at the nipple, noting any discharge. Medium deep, light, medium deep. So I noted throughout the breast, the tissue was consistent. There were no hard or immovable lumps or bumps, no discharge from the nipples. And now I'm going to be assessing the pericardium. You can put your arm down for me. I see no lifts, no heaves, and no deformities, and no impulses. I'm now going to listen with the bell of my stethoscope again at all the valves of the heart, listening for any murmurs. Just starting again at the aorta, the aortic, second intercostal space, right sternal corner. S1, S2, no murmurs. Pulmonic, S1, S2, no murmurs. Tricuspid, S1, S2, no murmurs. And finally, fifth intercostal space, mid-clavicular line, S1, S2, no murmurs. And I'm going to also find my apical pulse. And that's at the fifth intercostal space, again in the clavicular line. It is not displaced or enlarged. So now I will be moving on to the abdomen. If you can pull up your shirt for me. I'm starting with just assessing the abdomen for contour, skin pattern, skin color, venous pattern, and looking for any massive lesions and any noticeable changes in any striae or scarring. So now I'm going to be listening first to the abdominal arteries with the bell of my stethoscope. So first I'm going to listen to the aorta. And then the renal. And then the iliac. And I hear no bruits. Next, I'll be listening to the bowel tones in all four quadrants of the abdomen. And I hear normal active bowel tones with gurgling, no hypoactive or hyperactive sounds. They're all well spaced with no gaps. Next, I'm going to be lightly tapping on your stomach. You just let me know if anything's painful for you. So percussing in a straight lawnmower pattern. I hear tympanic percussion sounds throughout the upper quadrants and just a little bit of dullness in the left lower quadrant, which is common finding indicative of some stool. I know fluid, air, or signs of masses. Next, I'm going to be lightly touching your stomach. Just let me know if anything's painful or tender. So using light palpation on all four quadrants just to get the patient used to my touch, noting her face for any pain. If you'd like to bend your knees a little bit for this, that's helpful. Now I'm going to be pressing deeper. Let me know if there's any pain with that. Now I'm deeply palpating, assessing for any, no masses, no guarding or tenderness or rigidity. Next, I'm going to be doing a technique that assesses for your liver. So you're going to feel me along your rib line here with my fingers, and I want you to take a nice big deep breath for me. And slowly breathe out. And I do not feel the edge of the liver, which can be a normal finding. Now I'm going to reach across and I'm going to do the same to feel for your spleen. So reaching underneath with my left hand on CPE, and then go ahead and take a deep breath in, breathe out. And I do not palpate the spleen, which is an expected finding here. So you can put your shirt down, move down and assess the femoral pulses here in both groin. You're going to feel me touching your groin area, okay? And femoral arteries are 2+ bilaterally, not bounding or thready. Rate is approximately 75, and rhythm is regular. I'm going to be feeling your hips now. Let me know if anything's painful or tender. So helping in the hips, I don't feel warmth or swelling. And moving down the legs, as I assess the legs, I'll look for asymmetry, any muscle atrophy, any pain, warmth, swelling, or tenderness. Any pain there? Can you squeeze your muscles for me? Good, and relax. Assessing the quadriceps, I don't note any atrophy or swelling. Feeling the patella, the tendon of the knee, and the joint lines. Any pain or tenderness there? Okay. Moving down the shin. Any gastrocnemius, any pain or tenderness there? And they are symmetrical throughout. Feeling the ankles and feet. I don't notice any tenderness, warmth, or swelling. Any pain there? Okay. Feeling bilaterally for the dorsal PDS pulses. Again, they are 2+ out of 4, not bounding or thready. Rate is approximately 75, and rhythm is regular. We're going to go through some range of motion in your hips now. So I just want you to relax your leg into me. So bend up. We're looking at flexion of the hip and then flexion of the knee, and then extension of the knee. Back down. Any pain or tenderness there? I'm going to reach across to stabilize the hip. Now we're going out for abduction of the hip and then back in for adduction of the hip. And then I'm going to bend you at the knee again here, and we're going to rotate in. That's internal rotation of the hip and external rotation of the hip. Now we're going to do the same on the other side. So just relax into my hands there. So that's flexion of the hip and then flexion of the knee and then extension of the knee and back down. I'm going to put my hand here on your hip, and we're going to go out for abduction of the hip and then adduction of the hip. We're going to bend this knee one more time for internal rotation and external rotation of the hip. Great. So full range of motion in both hips. Any pain or tenderness with any of those movements? Great. Now we're going to do range of motion in your ankles. So first I'm going to have you point your toes to your nose, and that's dorsiflexion. Now you can put your toes toward the floor. That's plantar flexion. Now turn the soles of your feet towards each other. That's inversion. And then turn the soles of your feet out away from each other. That's eversion. Wonderful. Now I'm going to have you sit up for me. Swing your legs over the side of the bed. So next we're going to do some coordination practice. So you have your hands kind of there already. Put your hands on your thigh for me. You're going to splat your thighs with the palms of your hands and then the backs of your hands. And you're going to do that as fast as you possibly can. So, good. You can stop now. So cerebellar movement is smooth and intact with no clumsiness or irregularities. Next, I'm going to be checking the reflexes in your tendons. Start with your biceps here. Just try and relax your arms as best you can for me. Good. Relax your arms here. Good. So 2+ bilaterally in the biceps. Now I'm going to have you just hang your arm here for me. Try and relax as best you can. Good. This triceps 2 bilaterally, 2 out of 4. Brachial. Good. Relaxing. Okay, and that's 2+ bilaterally. Now I'm going to look at your knee tendon. Looking at the patellar reflexes. Okay. 2 bilaterally in the patellar tendon. Now looking at the ankle. Okay, and 2 bilaterally in the Achilles tendon. All done with tendon reflexes. So next what I'm going to have you do is stand up for me. And I'm just assessing the spine, looking at the concavity of the cervical and the lumbar spine and the convexity of the thoracic spine. I see no noted or pronounced kyphosis or lordosis. And can you turn for me? And shoulders and hips are even. Go ahead and touch your toes for me. This is flexion of the spine, and I'm noting no scoliosis. You can stand back up for me. I'm going to just place my hand for your balance and then go ahead and lean back. Okay, and that's extension of the spine. Now, look over your shoulders without moving your legs. Okay, and that's, oh, yeah, there you go. That's rotation of the spine. And now slide your right hand on your right thigh. That's lateral bending of the spine. Okay, so all spine range of motion is intact. Go ahead and turn around and look at me. Now what I'm going to have you do is stand on one leg, and you're going to bend down at your knee, and that's single knee bend, okay? And then do that on the same on the other leg. So that's equal lower extremity strength, and balance is intact. Okay, and next I'm going to have you walk for me. So I have you, you're going to walk out and walk back. And then have you walk on your tiptoes for me, and then walk on your heels for me. And with walking, I'm seeing an even gait, seeing even arm swing, no shuffling. Now I'm going to have you walk with one foot in front of the other. Good. And that's called the tandem walk. And back. And I'm seeing no leg, no shuffling, and good balance. So that completes my physical assessment. You can sit down if you like. I will now be talking through the male GU and female GU exam. So for a male GU exam, I would have have the patient position in a standing position. I'd be seated. I would don gloves, and I would talk through what, when, and where I'll be touching the patient. I would start by visually assessing the patient for maturity, any erythema, masses, lesions, any sign of scoriation, or any infestation. I would then assess the shaft of the penis, palpate the shaft of the penis, and note if the patient was circumcised. I would then look at the glands of the penis and ask the patient to retract his foreskin if he has any, to assess for any signs, again, of any lesions or exudate. Would then look at the urethral mediatus and assess for any signs of drainage. Moving on to each testy, I would palpate individually the testy and then the spermatic, the epididymis, looking for any nodularities, masses, and move up the spermatic cord using one finger, moving up into the inguinal ring, and ask the patient to turn and cough, so assessing for any inguinal hernias. I would do the same on the other side. When I was done assessing both testes, then I would move on to the prostate exam. I would have the patient stand in a standing position, bent over the exam table. If that was not comfortable for him, he can lay in the left lateral position. I would then have him don a new glove with lubrication. I would have him bear down as I placed my lubricated finger in the rectum. I would assess for the lobes and median sulcus of the prostate, feeling for less than 1 centimeter of protrusion. The prostate should be not warm or tender. It should be eraser-like in feeling, and should not be boggy. I would then do a 360 circulation of the rectum to assess for any masses or lesions, and then I would extend my finger and gently remove my finger, and if there was any stool on my glove, I can send it for occult blood stool testing, and then I would help the patient clean up and have them get them back into a seated position. Finally, I would, assessing the female, I would put her in a lithotomy position. I would then assess, don gloves, and let her know where and when I'll be touching her. I would let her know by the back of my hand on her thigh where I am before touching her genitals. Then I would assess the mon pubis, the major majora, the minor majora, labia, assessing the clitoris, the introitus, the anus, the perineum, looking for any drainage, exudates, hair distribution, maturity, and any lesions, warts, or masses. I would then let her know that we'd be proceeding with a speculum exam. I would have the speculum placed in warm water, and I would then place one of my fingers in a downward position before entering with the speculum at a 45-degree angle. Once I was in the introitus, I would start to turn the speculum horizontally. Once I was completely into the vagina, I would start to open my blades to assess for the os and cervix. If the os and cervix are not visible, I can remove slightly and exert upward pressure. Once they are visible, I can lock my blades and do my assessment of both the cervix for any drainage or lesions and the vaginal walls as well. Once I'm done with my assessment, I remove the blades from the cervix before closing the blades, and then exert some downward pressure as I remove the speculum. Once my speculum exam has been completed, I would then move on to the bimanual exam, placing lubricated fingers of my dominant hand inside the vagina. I would assess the vaginal walls for any masses or lesions, and then assess the cervix wiggle my fingers back and forth for any cervical motion tenderness, noting the patient's face for any pain. I would then, with my other hand, use a sweeping motion along the abdomen, assessing for the uterus size and shape, and then moving my fingers along with what side I am assessing. I would do a sweeping motion to assess for the adnexi on each side, assessing for any pain or tenderness and the size and shape of the adnexi. And then I would remove my fingers and help the patient back into a regular seated position.